I'm preparing for my step 3. These are some of the things I'm reviewing, and I just thought to, share. Maybe we can all review and learn psych together. So today I just want to focus on mood disorders. So when we talk about mood disorders, you think of depression, you think of mania. So first, let's talk about bipolar. So we have bipolar 1 and bipolar 2. So in bipolar 1, you just need an episode of mania to diagnose bipolar 1, okay? So that is to say that if somebody comes and then they have mania, first episode, you already anticipate that this is bipolar 1 disorder. They might go on to have depression later in the future. You can even ask them, has there been any episode of depression? Just describe the symptoms to them in the past. But the key to bipolar 1 diagnosis is that we don't need depression to diagnose bipolar 1, okay? And then in bipolar 2, we have hypomania and depression. So one episode or more of hypomania and one episode or more of depression, so this is the difference. So now if they give you a patient who suddenly is acting out of the ordinary, so they have increased energy, irritable, they have these delusions, and the delusions are grandiose. So only big things. Maybe they've met God, or God has asked them to solve what problems, or they are going to be on a ship for 1 day, 1 week. Some really, really, really weird big thing they want to do. They're going to have this impulse inhibited, like their impulse control would be bad. So maybe someone that has been gambling, or maybe a husband that has carried all their life savings to go and pour into something, because he has to do this, or somebody who quits his job, it's going to be some really bad thing, and then they've not slept in like 4 days, 5 days, and their energy is still very high. They've not been sleeping. What else? It has actually a ton of symptoms. But now in mania, for us to diagnose mania, remember that it has to have been there for 7 days or more, okay? If it is less than 7 days, we can't say it is mania yet. Why for hypomania? Hypomania is like a toned down version of mania. And in this case, we need 4 days or more to diagnose. We don't need up to 7 days. So it could be somebody that she's not been sleeping, but maybe she's been getting 2 hours. So anything you think of mania, just think of a toned down version. Yes, this looks like mania, but it's not that deep. It's not that serious. That's going to be hypomania. She tells you that, there are actually periods of my life where I actually thrive on less sleep. Maybe during my exams, I don't sleep and I'm good, but they're not, the symptoms are not too much to cause some really deep or really serious functional decline, so that's hypomania. And then if you see that and then you see one episode of depression, you can call it bipolar 2 disorder. Something you should know is that psychosis is maybe or may not be present in bipolar 1, but you don't see psychosis in bipolar 2. So what do I mean by psychosis? You remember we talked about delusions. Psychosis is just, when I think of psychosis, I think of delusions, hallucinations, and disorganized speech or thoughts. So in this case, you can see psychosis here. And remember that we said the psychosis are going to be grandiose. Delusions are going to be grandiose mostly, not paranoid, not the other types, but usually grandiose. Remember the themes. They've met God, they're big, their president has given them this mandate to do this, and so that's it. And then let's talk about the symptoms, not the symptoms now, the treatment of mania. So this is like something that step 2 loves to test a lot. In step 1, I think is mostly limited to lithium, and then they like to ask about renal clearance, or someone whose creatinine is over the roof, having symptoms of lithium toxicity, or a pregnant woman, and then what cardiac anomaly with her baby have, Epstein's anomaly, But then when it comes to step 2 psych, we have like a ton of drugs that we can use to treat or maintain mania or bipolar. And then we're going to have mood stabilizers and antipsychotics. So now let's dive right into the details. If a patient presents with acute mania, so they are presenting with acute manic symptoms, remember that acute mania is a psychiatric emergency. So what we want to do first is to manage them with antipsychotics or lithium or valproate. Now, what are the caveats? What do we need to know for each one? So remember, antipsychotics have 2 generations, first and second. That's typical and atypical. So for this, anyone can work. So the most ones that I've seen in the course of my review have been quetiapine, risperidone, haloperidol, and olanzapine. I've seen these ones come up mostly. And then lithium, remember, lithium is our prototype manic medication, and then it's always important that you remember that you should not give lithium or be careful with lithium in renal disease. So if the manic patient has renal disease, they won't tell you it's renal. They might just give you creatinine or give you some symptoms. Then you want to be careful and maybe try other things. The other one that is also pretty common is valproate, and they would give it to you in someone who is liver disease, and they would tell you that like they'll give you options. So if you see liver disease, AST, ALT, that kind of thing, you don't want to give valproate. You want to hold on to that. Now, if this mania is severe, like the psychotic features are way over the roof, they are aggressive, and you see that actually they are at risk of harming themselves or others, you want to now combine medications. So you're either giving your first generation or second generation antipsychotic plus the mood stabilizer, right? So is either you are giving, for example, your quetiapine plus lithium or valproate, that's like what we mean. You combine antipsychotic and mood stabilizer. Now, if remember that bipolar 1 also includes depression, right? So if they are presenting with acute depression, you want to also go in with atypical antipsychotics like your quetiapine, your lorazepam plus a mood stabilizer, your lithium, your valproate, your lamotrigine. Remember that they always love this in step 1, that when you give someone whose depression is part of bipolar, when you give them SSRI, you might want to you might tip them into mania and precipitate manic symptoms. So you want to be careful. You rather give antipsychotics and mood stabilizers. But then I've also seen places where they say if you give antipsychotics, then you can now go ahead to give SSRIs. But for the purpose of the test I've seen, you want to just give antipsychotics and a mood stabilizer. And then we have maintenance therapy. So that's like where you give them to be stable so that they don't have these acute symptoms, acute exacerbations. And remember, again, your mood stabilizers, your lithium, your valproate, and what's that other one, lamotrigine. Okay, and then remember quetiapine as well. So you're going to say it in your real world in your MBMEs, right? So there's also times where you see manic-like symptoms, but this person is not having mania. So remember that your dopamine agonist can be used to treat things like Parkinson's disease, restless leg syndrome. So this one has been commonly implicated, at least in questions, ropinirole. So giving it to them can cause side effects of this impulse control disorders. So you might see all those gambling, big shopping, things that would look like mania. So we have to be careful. You would look in the history, and then you will see that this drug was given. So this is not acute mania, okay? Now, let's talk about cyclothymia. So before we talk about cyclothymia, persistent depressive disorder, dysthymia. So if you're giving a patient who this person is having depression, but their depression is not too much, so like a toned down, the way hypomania is a toned down version of mania, you're seeing a toned down version of depression, of MDD, major depressive disorder, that is not that serious. They have just a few symptoms. Yes, they have that depressed mood, but they might not have feelings of self-worth, the feeling of harm, the suicidal ideation might not be there, right? So if you see that, and you see that for the most of their life, they've been like this, we are thinking of dysthymia or persistent depressive disorder. So the criteria is that it should be present for 2 years, and they should tell you that for most of those 2 years, they've been feeling like this. If there are periods where they're not feeling like this, then it shouldn't be more than 2 months where they are symptom-free, okay? So, and then in adults, we said already, you need 2 years, and in children or adolescents, rather, you need 1 year or more, it's okay. Now, cyclothymia, like the name, cycle. So cyclothymia is when you have like cycles of hypomania and depression in a cycle. Sometimes hypomania, sometimes depression. And also, it needs 2 years to be diagnosed in adults and 1 year or more to be diagnosed in adolescents. Okay, now let's talk about MDD. So MDD, you're going to see somebody, a patient who has depressed mood. Everybody can identify what a depressed mood is. Their mood is low. They have anhedonia, like the things that used to give them joy, the things that they used to be interested in. So they'll tell you that they don't want to play golf again. They don't want to visit. They don't want that grandchildren visiting them anymore. They don't want to be on the phone again talking to their family, their friends. So the things that used to make them happy, they don't want to do that again. There are also feelings of guilt, problems in concentration, appetite changes, either decreased or increased appetite, sleep disturbances, increased or decreased, okay, sometimes suicidal ideation. So we need 5 or more symptoms to diagnose, and out of those 5, 1 must be either depressed, guilt, or anhedonia. So even if you have the other 6 and you don't have any of these, we can say it's MDD, and it has to be present for 2 weeks or more. If it is 1 week, we can diagnose MDD, okay? And yeah, I just remember that there are cases where elderly people would have hearing disorders and they don't want to be on the phone, so they give you that and they put depression there. No, they also give you some things to tip you that this person has hearing disorder. So the reason why he's not on phone is because it's stressful for him to keep, like, people don't hear him, he does not hear people, you know, that kind of thing. So yeah, they might not want to have those conversations again over the phone, but this is not depression. So usually in psychic disorders, you have to look for, like, psychic disorders can have overlap of symptoms. So that's why we have all these criteria, so that if something else fits more, you can't choose one answer. I hope I'm making sense so far. Yeah, we mentioned about mania in pregnancy, where we are scared for lithium. So if they give you the option of haloperidol for acute mania in pregnant women, you might want to take that. Okay. So now let's talk about the antidepressants. These are like a big group of medications, and you will almost always see them when you're studying psych or doing any psych exam. So let's get right into it. I've heard that there is no superior one. Yes, we have the ones that are first line, but they're saying that there is no superior or inferior. It just depends on comorbidities and what you're trying to achieve. Okay, so the first group is our SSRIs. SSRIs are, I don't know, you keep seeing them. I don't think there's any drug that is as repeated as they are. There's this rule of thumb that if you don't know what the answer is and it's not an antipsychotic you should almost always go with an SSRI. You might never be wrong. You know the way people say that if you know the answer, pick C, you might be right. So this is how SSRIs are, because they are used for treating a lot of things apart from depression, generalized anxiety disorder, OCD, you know, phobias, PTSD. So yeah, that's why they're pretty common. So let's talk about them. The SSRIs are like citalopram, escitalopram, fluoxetine, paroxetine, sertraline. So what are the caveats from step 2? That in general, SSRIs are going to cause sexual dysfunction. That's the first thing you should know. They will cause sexual dysfunction. So you might see a guy who comes and is complaining of loss of libido and things. If he's not sexually active and it doesn't bother him, you might just explain to him that this is a side effect that you're expecting. But then if he is bothered by that, or he needs a change, then you can change the medication. And the most common one that you change is bupropion, because it doesn't have sexual side effects. And also, SSRIs can cause serotonin syndrome, especially when they are combined with other serotonergic medications. Yeah, what else is important for SSRIs as a group? They take 4 to 6 weeks to work, right? So there's something called receptor downregulation. So the receptors, I think about it like we have a surge of serotonin all of a sudden, and then they have to downgrade the receptors a bit to, and then maybe they get used to it, and then they see that we actually want all this serotonin, and then the receptors before they begin to work. So they're going to tell you a patient who they've come for a 2 weeks follow-up after starting SSRIs, and then they would ask you, the person will tell you that, oh, I still feel depressed, I don't feel better. So they'll ask you that, should you wait, should you change their medication group, right? So you want to tell them that you should wait a bit, that it takes 4 to 6 weeks to take full effect. Okay, so what's special about each one? I would say, okay, fluoxetine, I remember it's used also to treat eating disorders. So I've seen that. And sertraline is best for cardiac problems. So when somebody, for example, has had an MI, you want to give them sertraline. This is important because you should avoid citalopram in MI patients because it causes QT prolongation. Also, sertraline is the best, safest for breastfeeding. For pregnancy, it doesn't pass the breast milk. So if they give you a pregnant patient or a breastfeeding patient, you want to go to sertraline, right? Then let's talk about serotonin SSRI discontinuation syndrome. SSRI discontinuation syndrome has like a ton of symptoms, but the first one should be anxiety. I'm just going to read out the rest. So anxiety, dysphoria, they will have flu-like symptoms, runny nose, just like flu, and they would have dizziness, problems with their GI. And GI symptoms should be easy to remember because serotonin just likes GI things. Even serotonin syndrome, you're going to see GI things. In carcinoid syndrome, you're going to see GI things, diarrhea and the rest. There's also things like paresthesias, electric shock sensations, and vivid dreams. And it's important to know that this serotonin discontinuation syndrome is people who are more prone to it are people who have anxiety disorders, because remember, anxiety is like one thing. And I think the best what you do now is you reinstitute the drug, give them the drug back, and I guess you taper it off and they get used to it. And remember that we already spoke about SSRIs causing sexual dysfunction. So guess what? We're going to use that to treat premature ejaculation, because if you're causing sexual dysfunction, if somebody's ejaculation is coming too much or too early than we would like, we can give SSRIs. So that's actually one of the drugs we give. Another drug we give is topical anesthetics like your lidocaine, prelocaine. And remember, your TCAs also have analgesic properties, so you can also give that anesthetic properties as well. And then, of course, therapy, couples therapy, joint couples therapy. Is there anything else I forgot to mention? In mania, one of the things that are very important to diagnose mania is their speech. Their speech is pressured, they're talkative, like you can't interrupt them. This is very important because you're going to see the opposite of that in schizo. Schizo guys don't even talk much. Right, they don't give you many words, but in mania, they talk, pressure speech, talkativeness. Okay, so is there any other thing that we want to talk about in SSRIs? I should also mention that the neurotransmitters are low in depression. Everything is low. Catecholamines, your serotonin, your norepinephrine, your dopamine. That is why all the drugs we're going to be talking about are going to be aiming to increase levels of these neurotransmitters by inhibiting their reuptake. Right, so the one you spoke about inhibits reuptake of serotonin. Let's talk about SNRIs. This one will inhibit reuptake of both serotonin and norepinephrine, right? And they also have anesthetic properties. That is why you're going to see some of them being used to treat fibromyalgia, right? Neuropathic pain. Okay. Your SNRIs are your venlafaxine, your desvenlafaxine, your duloxetine. So painful diabetic neuropathy, fibromyalgia, and they give you options. If you see duloxetine there, that's a good option. And then what is special about venlafaxine, the thing is that you cannot give it to people that have had recent MAOIs contraindicated because it's going to cause tachycardia and BP increase. Remember, it's going to also inhibit reuptake of norepinephrine, and norepinephrine is a sympathomimetic, right? So remember that this is contraindicated in recent MI. You also want to remember the one that is best for cardiac problems, that's sertraline, right? So let's talk about norepinephrine dopamine reuptake inhibitors. So the star of this one is bupropion. It increases norepinephrine levels and increases dopamine levels. So what makes it so special is, one, remember we said it doesn't have sexual side effects. It's approved for smoking cessation. So if somebody is bothered by sexual side effects of SSRI, this is a good option. If someone that is depressed and is also wanting to quit smoking, this is a good option. It doesn't have weight gain, so this is good. So if someone is gaining weight and they're depressed and they're bothered about it, this is a good option. However, it is bad for people that have eating disorders, like your bulimia, your anorexia. Is also really bad for alcoholic withdrawal. So anything that would tamper with your electrolyte levels can cause seizures, and bupropion decreases seizure threshold, right? And remember that we said SSRIs can be used to treat eating disorders, bulimia. Yeah, fluoxetine is one of the drugs used to treat that. So these are like just integrations and relationships. So now let's talk about TCAs. TCAs are like really interesting group of drugs. They are very helpful, but they have these side effects that make them scary to use, especially in adults. So your TCAs are amitriptyline, nortriptyline, imipramine, clopramine. So TCAs are not only used for depression, they also have analgesic properties. So they're used for pain, they can be used for migraine, they can be used for diabetic neuropathic pain, they can be used for premature ejaculation as well, right? So the side effects are cardiotoxicity. You're going to see widening QRS, which can lead to ventricular arrhythmias. So we're scared of that. And if that happens, because it blocks sodium channel, so if that happens, we want to give them sodium bicarbonate to combat that. And then if actually overdose, it can be pretty lethal. Overdose can be pretty lethal. So I think it's also one of the drugs that people can use for suicide, if I'm not mistaken. Right. So what even makes them really bad for adults, that is they always love to test it. Right, so they block these receptors called anti-harm. It's an mnemonic. They block histamine receptors. They block alpha-1 receptors. They block muscarinic receptors. So if you block histamine receptors, sedation. If you block alpha-1 receptors, orthostatic hypotension, so dizziness, falling, and you are scared of that sedation and dizziness and orthostatic hypotension. You remember they can cause falling in elderly people. So we are scared of that. Then anti-muscarinic properties, they can cause dry mouth, can cause urinary retention, which is bad for elderly people too, can cause UTIs, right? So these are like some of the things that you should keep in mind. Let's talk about your MAO inhibitors, monoamine oxidase inhibitors. So monoamine oxidase is an enzyme. There's A and B, so they break down catecholamines, right? So remember that we said our aim of treating depression is to increase these catecholamines. So if we inhibit the inhibitor, then we can increase it, right? So also have some side effects that are pretty worrisome. So even though they are an interesting group of drugs, a good group of drugs, they can have problems with side effects. So they are not prescribed as first line in most cases. So the examples we have are phenelzine, neocypromine, sorry about the drugs, and selegiline. So this selegiline is used for treating Parkinson's disease. So you might say it as the reactions that we have. First, it's about serotonin syndrome. So when you give it together with SSRIs, or immediately after giving SSRIs, or discontinuing SSRIs, you can increase your levels of serotonin, and that can lead to serotonin syndrome. So usually there's always like a washout period between the use of this one. For example, if you give more inhibitors for a while and you want to introduce SSRIs, for example, there's always like a washout period because we want to regenerate the monoamine oxidase. Because yes, in as much as we want to increase serotonin and all of this, we don't also want to increase too much, in the sense that we still want things that would, balance out or inhibit them when necessary, right? And so you can see this when you give it together with serotonin drugs. You can also see it when you give it together with linezolid. Remember, the linezolid is an antibiotic, but it also has serotonergic effect. And the one that loves to get tested all the time is when somebody's taking monoamine oxidase inhibitor and then they go for a party, or they tell you that they went to dine and then they had this wine or cheese. So tyramine is something that is present in wine, cheese, and tyramine is a sympathomimetic. So it has the ability to shoot your BP up and cause hypertensive urgency. So normally monoamine oxidase should break down tyramine in the gut, but in these people, the monoamine oxidase is inhibited, and what happens? Tyramine is there to do its thing, so they will always come in with hypertensive urgency. So yeah, this is something to keep in mind. Another one is trazodone. Trazodone can inhibit alpha receptor as well, so lots of that vasodilation, lots of it can cause orthostatic hypertension as a side effect. And the one that is also really commonly tested is priapism. It can cause priapism because remember what causes erection. Erection is caused by vasodilation, right, in the penis. Your what's that thing called? That's cavernosa, the corpus cavernosa. So when all those veins are engorged, or there's like a lot or the blood there, and then that's how erection happens. So priapism is abnormal, is prolonged, painful erection. So trazodone is commonly implicated. So you want to know that. So how do you treat? You give them alpha-1 agonist that would constrict the blood vessels and channel the blood away, like your phenylephrine. Your bupropion also has some stimulant effects, like it can cause wakefulness. It can stimulate. So if somebody is depressed and has issues with concentration, they are just drowsy and all of that, bupropion also might be a good option. Maybe they want to go to work, or they really need something to wake them up. That can also be a good option. I'm just trying to think, see, there's like anything I forgot. Okay, so now when we have like resistant or severe depression, or depression that is prolonged, or depression where the suicide risk is imminent, like we want to really combat that immediately, something we can do is ECT. ECT is electroconvulsive therapy. So it involves putting some fancy electrodes in your brain and inducing some kind of seizure. So it's pretty safe. Yes, it sounds like a big thing, but it's actually pretty safe. It's safe in pregnancy as well. So that's like a big one. It's safe in pregnancy. And the side effects that is commonly tested is retrograde amnesia, and there are no absolute contraindications. That means that anybody can do them. However, you might want to know that there's increased risk of this amnesia in people who have like some space occupying lesions in the brain, or people who have unstable aneurysms, recent stroke, severe cardiovascular disease, or recent MI. So you might want to be careful, but then there are actually no absolute contraindications, and it's pretty safe. And remember that indications are for depression that is pretty resistant to medications, in pregnancy as well, in cases where they are refusing to eat or drink, or where psychosis is pretty present. Now, how do we make a decision on how long antidepressants should last? So we have 3 phases. So we have a continuation phase, we have maintenance therapy, and then we have lifelong therapy. Well, it's not official, but that's how I like to classify it. So in continuation phase, these are people that they had one episode, it has resolved. This is not bipolar. This is unipolar major depression. One episode resolved, so you can keep treating them for up to 6 months, okay? However, if these are people that they have more than one episode, depression started at a very early age of onset, the severity is much, they are suicidal, they have ongoing stressors, so things that can easily tip them back into depression, and then they have persistent residual symptoms. So all the symptoms of depression haven't gone. This guys, you want to think of maintenance therapy, so from 1 year to 3 years. Or however, if it is highly recurrent, so these are like people that in a lifetime they've had more than 3 or more episodes, they have strong family history of depression. The episodes are chronic, like up to 2 years depressed. And then if their episodes are usually severe, where they actually like attempt suicide, that's how severe their depressive episodes are, you might want to keep them indefinitely on drugs until you can review. Let's talk about atypical depression. So this is depression that is not typical. And what makes this atypical is that they have hypersomnia, sleep a lot, eat a lot, and 3 specific things: leading paralysis. So their arms, their legs feel heavy. Then they have this very sensitive reaction to rejection. So they are hypersensitive to rejection. And then their moods get better when good things happen. So they're also really sensitive to good things, and their mood gets better. So for those ones, you diagnose them with atypical depression. You treat with cognitive behavioral therapy plus or minus SSRIs, and your monoamine oxidase inhibitors also really work well for this group. So you may want to consider that. But remember what we said about side effects. Another type of depression is seasonal depression. So these people, they are depressed during some seasons. So when the daylight is decreasing, like in your autumn, in winter, they get depressed. In spring and in summer, they get better. For them, you also want to give them antidepressants and bright light therapy. So when they wake up, you give them bright light therapy. So 10,000 lux walks, I think maybe just to simulate that daylight, that helps them, right? So now let's make an association with between major depressive disorder with psychotic features and schizoaffective disorder. So major depressive disorder with psychotic features are people that when they are depressed, they have symptoms of psychosis. Remember your hallucinations, delusions, disorganized speech plus or minus. So that means that when they're not depressed, they don't have any of the psychotic symptoms. Their psychotic symptoms come only when they're depressed. So for these people, we diagnose them with MDD, with psychotic features, and then it's no surprise that the treatment will be antidepressants plus antipsychotics, right? However, schizoaffective disorder are people who have psychotic symptoms primarily, but when they have psychotic symptoms, they now have depressive or manic episodes. So that's like the opposite. So you have to identify what is the primary disorder. If it is depression and then with superimposed psychosis sometimes, then that is MDD with psychotic features. But if it is a psychotic disorder and then during their psychotic disorders, they will have either manic episodes or depressive episodes, this is schizoaffective disorder, right? So for these people, that means that there are actually going to be times when they have their psychotic episode without depressive or manic episodes, okay? So yeah, that's like a very confusing concept in psych that you should keep in mind. Let's review the sleep pattern, the changes in sleep pattern in depression. This is something that they really love. They love to contrast it with sleep pattern in normal aging. So in depression, there is increased levels of cortisol. So your hypothalamic pituitary axis, your HPA axis is hyperactive. So what happens to these people is that it doesn't take them time to get to REM sleep. So that's decreased REM sleep latency. And then when they get to REM sleep, they stay longer in REM sleep. So that's increased REM sleep duration. They also have decreased slow wave sleep. Then you will see decreased hippocampal and frontal lobe volume. So if they give you that in MRI, you might want to think of depression. At this point, let's talk about things that can cause depression, but this is not MDD. These are medical causes of depression. So the most common one that they'd love to ask would be hypothyroidism. But then, yes, you see weight gain, you see the sluggishness, but then there are also other things that will cause hypothyroidism that will be in the question stem that will let you know that this is not MDD, this is depression caused by hypothyroidism. So they might give you levels of cholesterol, they might give you the skin changes in hypothyroidism, and then the next, or even the bradycardia, for example, and then your next best step would be to check your thyroid function test. TFT or your thyroid levels. Something else that can cause it is multiple sclerosis, Parkinson's disease, Huntington's disease, someone that has had a recent cancer diagnosis. Those kind of things can actually cause depression. SLE, stroke, acute intermittent porphyria, beta blocker therapy, interferon alpha therapy. You want to keep these differentials in your mind. And then something else that they also like to confuse or bring together with depression would be grief. So in normal grief, they are sad, they are teary, they might even think of death, and their themes of death would be that they want to join their loved ones. They might lose interest in the things that they normally do, but you would see that, one, their sadness would always be related to the death of that person. So even if they say like, actually wish I could die and join my husband or my father or somebody, you would see that they're not like, no, they're not telling you that they're going home now to kill them. So that's suicide intent. Okay, that's different. That's scary. And then that's normal grief. And then if it passes 12 months, it's no more normal grief. Again, you want to do something about that, right? And in normal grief, they are still functional. Their symptoms are not enough to impact their functional ability. Okay, psychodynamic as well. They are good cognitive. They are okay. All right. And since we've already mentioned lithium in mania, let's talk about lithium toxicity, how it presents, and what are some of the side effects of lithium therapy. For lithium toxicity, we have acute and chronic. So acute is probably intentional overdose. Somebody really pumped themselves with lithium. So we're going to have nausea, vomiting, diarrhea. So think of GI symptoms. So if you see GI symptoms and then later neuro symptoms like tremors, think of lithium toxicity. Now, if you see maybe lethargy, confusion, agitation over time, your ataxia, your tremors, your fasciculation, your seizures, think of chronic over time. And this is always caused when you have problems with your renal perfusion. Remember that the lithium is cleared by the kidney. So if you have any issues with your kidney, over time it can build up and like cause lithium toxicity. Something else can also be like maybe drugs that actually lower kidney perfusion. Might not even be CKD. Things like thiazide or dehydration, your NSAIDs, your ACE inhibitors. So think about them. And what do? You just try to hydrate. And if it is pretty severe, then you want to do hemodialysis. Okay. Now for side effects of lithium therapy, first one is your thyroid symptoms. Almost always, or more commonly, hypothyroidism. It can also cause nephrogenic diabetes insipidus, can cause CKD, can cause hyperthyroidism, so you see hypercalcemic symptoms, and then it can also cause, remember we talked about pregnancy in first trimester, cardiac anomaly, that's Epstein anomaly, and then one more thing that it can cause would be problems with heart rhythm in patients who already have coronary artery disease. So that brings me to the end of this first episode of the Psych Review. Just to recap, we talked about bipolar 1 and bipolar 2. The difference is that you don't need MDD to diagnose bipolar 1. So bipolar 1 is mania, plus or minus yet of MDD. But in bipolar 2, we need at least one episode of hypomania and one episode of MDD, at least. Talking about the symptoms of mania, impulsivity, I think it's dig fast, impulsivity, talkativeness, grandiose themes, distractibility, increased energy. You think of that. We talked that the psychosis in mania is usually grandiose themes. We also talked about monotherapy and combination therapy for mania. For acute mania is an emergency. For chronic, you want to keep them on that. So usually your antipsychotics and your mood stabilizers, your lithium, your valproic acid, your lamotrigine, your quetiapine, which is an antipsychotic. We talked about cyclothymia, that's the cycle of hypomania, and MDD. We talked about persistent depressive disorder, dysthymia. So that is when they don't have full-blown MDD. Even though later in life, if you keep monitoring them and they actually meet up to 5 of the symptoms of MDD, you can actually change your diagnosis to MDD. But for 2 years or more, these people are almost always depressed, right? So that's PDD. Then we talked about mania in pregnancy. We talked about antidepressants, your SSRIs, your SNRIs, your norepinephrine dopamine reuptake inhibitor, your TCAs, your MAOI inhibitors. We talked about atypical depression. We talked about MDD with seasonal pattern. We talked about major depression with psychotic features. And also remember that the mood disorder or the psychotic disorders in MDD with psychotic features are going to be mood congruent. So the delusions are going to be things of grief, guilt, feelings of worthlessness. They're not going to be having MDD with psychotic features, and the delusions are going to be big things or grandiose things like in mania. Okay, we talked about the treatment of these things. We talked about sleep patterns, and also talked about how the neurotransmitters in your dopamine, your serotonin, and norepinephrine are all low in depression. And then we talked about the medical causes of depression, the things that can mask to be MDD but are not, that if you treat these things or if you diagnose these things, you can alleviate or take them back to their pre-morbid state maybe. And then we also finally talked about lithium toxicity, the acute and chronic, and then the side effects of lithium therapy. So next time we'll be talking about psychosis and antipsychotics, your schizophrenia and the likes. So I hope you guys found this helpful, and if you have any ideas on how you want me to make it better or what you would like to see, please drop it in the comments. This is new for me and we are all doing this together and growing together. So if there was like anything I said that I shouldn't have said or a mistake I made, so just like put it in the comment section and yeah, we would correct ourselves and learn together. All right, so I'll see you guys next week.